So let's going to start today's Vijaya Diagnostic Educational Webinar Series. I am Dr. Dileep, working as a consultant radiologist in Visakhapatnam. And these educational webinar series we are conducting since few years, in which there will be a good interaction between the clinician as well as the radiologist regarding various topics. These interactions will enhance mutually the knowledge about the respective topic, which will help in better treatment and diagnosis for the patient. So today we have an interesting topic, and it is cardiac MRI in ischemic heart disease. As we all know, ischemic heart disease is one of the leading causes of morbidity and mortality in not only in India but across the world. So evaluation of ischemic heart disease is very important in the present scenario. And for this topic, we have two eminent faculty. And today's chief guest is Dr. G.Ravikanth. He is a senior intervention cardiologist from KIMS Secunderabad. I welcome you, sir. In spite of your busy schedule, you have accepted to graciously accepted my invitation to participate in this webinar topic. A brief introduction about Ravikanth, sir. He has done MBBS from Gandhi Medical College and MD General Medicine from Osmania Medical College. And he has done DM Cardiology from NIMS in 1994. And he worked as Assistant Civil Surgeon in Mancherial. And later worked as Assistant Professor in Cardiology Department in Osmania Medical College after completing his DM from 1994 to 1996. And later as Consultant Cardiologist in Mahavir Hospital till 2003. And later he joined KIMS Secunderabad as a senior intervention cardiologist, and from 2004, and is working till date in KIMS Secunderabad. And the areas of interest are invasive cardiology, clinical cardiology, and preventive cardiology. And he has participated in many clinical trials as a co-investigator and has many publications in various journals. He is a life member of Cardiology Society of India and Indian Medical Association and Association of Physicians of India. Warm welcome to you, sir.
Thank you.
And the expert speaker for today's talk is Dr. Deepak. He is my colleague working in Vijaya Diagnostic Center, Hyderabad and Himayatnagar branch. He's a senior consultant radiologist, working experience of around 12 years, and he has done MD, DMRD, DNB, Diploma in European Radiology and FRCR from UK. And his areas of interest are predominantly coronary CT and cardiac MRI. And he has spent special interest in cardiovascular imaging, breast imaging, fetal imaging, and prostate imaging. He has delivered several talks in IRIS state and national conferences, and authored a book in chapter about temporal bone imaging. Welcome, sir. So, as we all know, coronary artery disease, it's very important to differentiate between the ischemic and the infarcted heart, the part which is necrosed and the part which is viable, so that we can make a decision regarding the prognosis as well as treatment of the patient, and we can manage the patient well. So, recent advance. Previously, there was only like molecular, nuclear medicine, molecular imaging to differentiate myocardial perfusion and all that. But in recent advances of MRI, a lot of new techniques have come where there is better spatial resolution as well as better myocardial perfusion can be done on MRI. So we are doing these cardiac MR since few years, and Dr. Deepak is the expert in this cardiac imaging in our Vijaya Diagnostic Center. So I think this will be an interesting topic and discussion today. So I request Dr. Ravikanth sir to speak a few words regarding the ischemic heart disease, and when does he send the patient for MRI, and what are the indications, and how will you evaluate a patient with chest pain and cardiac disease. Over to you, sir.
Thank you for your warm welcome and introduction. Today's topic is very interesting, as you mentioned. It's a very valuable imaging tool in the assessment and management of all cardiac diseases, including ischemic heart disease, valvular heart disease, myocardial, especially myocardial, cardiomyopathies, pericardial diseases, including post-operative states, as well as congenital cardiac diseases and aortic dissection, aortic disease also. In particular, about coronary arteries, why we are more interested, because this is one of the leading cause of mortality across the globe, both in developed countries as well as in developing countries like India. And the in our country, it is more the heart disease, especially hard acute MIs. They develop 1 decade earlier. Average age is 1 decade earlier compared to European and North American population. So this is very important area where we can assess and manage properly so that we can prolong the lives and quality of life for the individual. So regarding the acute assessment of ischemic heart in a ischemic heart disease, one is quantification of the ischemia. Second one will be the viability. Why viability is important? Because especially in cases of post MI, where there is necrosed scar is issues significantly transmural or non-transmural, whether the rest of the myocardium or in the there any viable tissue in the necrosed area, because quantification is difficult to identification is difficult in when there is large area is necrosed, how much area is viable, so that we can properly assess them and completely revascularize, then the outcome will be better compared to routine revascularization such people. And second thing is chronic coronary disease. Sometimes they present with ischemic cardiomyopathy with severe LV dysfunction or moderate LV dysfunction. In such cases also, how much is ischemia component is this? And also how much is viable? These are the two important components for managing ischemic heart disease patients by utilizing cardiac MRI. This is about only coronary artery disease. We are focusing today. Our topic is only coronary artery disease. So we'll restrict our uh, imaging assessment in mostly in related to coronary heart disease, especially the ischemia as well as the viability assessment by cardiac MRI. Uh, Thank you, and over to Dr. Deepak for further uh, presentation.
Over to you, sir.
Right. So, good afternoon. And at the outset, I would like to thank Vijaya Diagnostic Center for this wonderful opportunity to discuss this topic, which is cardiac MRI and ischemic heart disease. Um, I would also like to thank Dr. Ravikanth sir for this clinical perspective he's given us and what we are expecting to see in cardiac MRI. And thank you, Dr. Dileep, for the kind introduction. I would like to straight away go into the topic. I have no relevant disclosures, and there's been fair usage of copyright material. Today's topic we are going to discuss in brief outline, which is we're going to first see what cardiac MRI is all about, how it is done. Then we are going to see why it is done, which is the indications of cardiac MRI. And we're going to see what exactly, how cardiac MRI helps in patient management and diagnosis in ischemic heart disease. And then we are going to see some of the images, what we have done in Vijaya Diagnostic Center. So coming to the procedure as such, cardiac MRI usually takes about 30 to 45 minutes. We have to be fasting. The patient has to be fasting for it, and it should have normal renal parameters, renal function. Okay, once this is there, and patient should not have any cochlear implant or aneurysmal clips. Sometimes they can cause problems in cardiac MRI. So once all these contraindications are not there, we can safely take the patient for cardiac MRI. And we do certain sequences for in this cardiac MRI to look at the disease in LV myocardium, that is the heart muscle. First, we do a black blood sequence, then we do a cine or real-time moving heart sequences, if you may say, and then we have the outlet imaging. We have newer modalities like parametric imaging, and also we do the edema imaging. And the most important sequence in cardiac MRI is called as the post-contrast late gadolinium imaging. This is what is the most important sequence in cardiac MRI to detect diseased myocardium. Okay, and then we do a flow analysis of the valves of the heart. Then if there is no information of angiogram as to what the disease of coronaries is, at least we can get some information in MRI, and we look for that in cardiac MRI. And in certain patients, not all the patients, we do a stress MRI with pharmacological agents such as adenosine and dobutamine. Now, like Dr. Ravikanth sir has already told us, there are certain indications what we look for and why we do cardiac MRI. First is we need to know the accurate ventricular function, that is the pumping ability of the heart. And then we have to see whether there is any diseased myocardium, yes or no. If there is a diseased myocardium, which arterial territory it is located in, and what is the severity of the disease in the myocardium. This is what we want to see. And then we also want to see what is the contractile reserve, that is the contractile power of the myocardium. And then we see the myocardial perfusion, that is the regional blood flow to the myocardium. And we also look for complications of ischemic heart disease, that is the complications of myocardial chronic and acute myocardial infarctions. Now, certain clinical questions what we can definitely and accurately answer is we can talk about the global and regional ventricular MRI. We can do accurate burden assessment of the myocardium, and if there is no information of the coronaries, we can also see a little bit of the proximal coronaries, but usually this information is already available when the diagnosis of ischemic heart disease is made by angiogram, either CT or conventional. Now I'm going to show some examples of the images in cardiac MRI, what we do usually. First, we start with the entire chest to look for extra cardiac abnormalities and the major vessels of the mediastinum. This is called a black blood sequence. And this actually is a cine sequence, which is sequence of the moving heart, where you can see that yes, I think you can see the very clear images of the moving heart. These are called cine sequence, where we get excellent information of the regional and global ventricular function based on these images. And then we have the edema sequence, which is very useful in detecting acute myocardial injury and differentiating it from chronic myocardial injury. And then recently, we are doing a lot of parametric imaging, which is T1, T2 mapping and extracellular volume maps, which is basically to look for any infiltrative myocardial disease. We're going to talk about this in the later part of this talk as well. And the most important sequence is the late gadolinium enhancement sequence, where we give IV contrast. We give an injection to the patient, and then after about 10 to 12 minutes, we image the heart, and we are trying to look for any non-viable or infarcted, diseased myocardium. And this is the most important sequence of cardiac MRI, which is the late gadolinium enhancement sequence. And at the end of the study, we get a software where we can calculate the ventricular function and get the various ventricular indices, functional indices, like this particular graphic what we're looking at. So we can get accurate information of the ventricular, both the right and left ventricular function. And in good quality studies is actually more accurate than the more commonly done echocardiogram. Now, we're going to quickly see what happens in diseased myocardium. Okay, if you look at the ischemic cascade, the normal myocardium, then there is hibernating stunned myocardium, or there is non-viable or scarred or infarcted myocardium. In the hibernating myocardium, the contractility and the perfusion, which is the blood supply, both are decreased, but there is a definite chance of recovery in this diseased myocardium. And in stunned myocardium, both the contractility is decreased, the blood supply is also initially decreased, but then again it is restored. Even this stunned myocardium has a chance of recovery. When you look at the non-viable, which is infarcted myocardium, both the contractility and the blood supply is decreased, and there is usually no chance of recovery. So MRI helps us in identifying the non-viable and differentiating it from stunned or a hibernating myocardium. So that is exactly the role of cardiac MRI, what we usually do. When we talk about non-viable or infarcted myocardium, basically what happens is the normal heart muscle is replaced by fibrosis and scar, and the contrast accumulates in this in delayed imaging in the interstitial space where there is cell membrane damage and damage to the capillary bed. So there are certain things what we look at, parameters what we look at in cardiac MRI to say that this particular part of heart is diseased and non-viable. So we look at the thickness. If it is very thin, of less than 5.5 millimeters, and if there is akinesis, if it is not moving well, and if there is enhancement in different degrees, like transmural, entire length of the thickness of the myocardium, or part of it, like in subendocardial enhancement. These are the things, parameters, what we look at to correctly tell that this particular part of the heart is diseased and not viable. Now, if we look at this graphic, this gives us an excellent way to differentiate between ischemic and non-ischemic myocardium. Now, if you look at the first two images here, what we can see is that the ischemic pattern of enhancement is typically transmural and subendocardial. It usually starts in the subendocardial layer and progresses outwards. Whereas if you see different other types of enhancement like epicardial enhancement or a mid myocardial enhancement or global subendocardial, these are the types of what we see, this pattern of enhancement, what you see in non-ischemic heart diseases. So just by looking at the pattern of enhancement itself, we can correctly tell that whether this is actually a disease due to blocked coronary arteries or some other infiltrative or inflammatory disease of the heart muscle. Now, this is an example what we've done in Vijaya Diagnostic Center. You can clearly see a transmural infarct with a sharp zone of transition. You can see the entire thickness of the muscle being abnormal and it is enhancing, right? And this is another example of a subendocardial infarct where you can see varying degrees of subendocardial infarction, where you can see as a enhancing subendocardial areas. Now, when we talk about subendocardial infarction, we need to again see whether it is a significant subendocardial infarct or not so significant. So that information we get based on looking at the thickness of the involvement of the muscle. If the involvement is less than 50%, we can confidently say that particular part of the muscle. If it is more than 75% of thickness involved, like in this particular territory here in LCX territory, that means it is non-viable. There is an area between 50 to 75% where we have to determine whether that part of myocardium is viable or not. In that situation, we look at other parameters like regional wall motion abnormality. So if there is an akinesis in that particular segment with 50 to 75% thickness of involvement, and then we can consider that as non-viable. And if there is hypokinesis of that particular segment, it is still moving to a certain extent, then we can conclude that it is a hibernating, viable, and there is a chance of recovery in this particular segment. Now, again, another important thing what we want to know is how do we estimate how much of the disease is there in the left ventricular myocardium? What percentage of the myocardium is diseased? So that we usually get by different softwares which are available widely in the market. One is called as pixel counting, and then there is full width half maximum, and then there are statistical segmentation software analysis. We also commonly use visual method where we have this heart muscle is divided into 17 segments based on the American Heart Association model, and we look at where there is scarring in the heart muscle and we add it up to get the final number or percentage of how much of left ventricular myocardium is diseased. Now, this is an important part of MRI, which is a stress MRI. This is not done in all the patients. It is done in selective patients. In this, there are two types. We give pharmacological agents like adenosine and dobutamine. Adenosine MRI is done to see the perfusion under stress. Dobutamine is done to see the contractile reserve of that of the left ventricle. I'm going to show. We're going to see what kind of patients really this kind of stress MRI is required. That is, imagine a patient has multiple blocks in coronary arteries. Okay, one of the blocks is 50%, one is 80%, and one is maybe 20%. You can presume that 80% is definitely significant plaque or obstruction, whereas 50 you're not sure. 50% whether you want to know whether it is a significant obstruction or not. To determine whether this 50% is significant or not, you can do a stress MRI, like an adenosine stress MRI, to see if there is any reversible perfusion defect. If that is there, then you can think that this 50% plaque also is significant and needs revascularization. So in such patients where you have a patient of CAD with indeterminate significance, you can do a stress MRI. and in patients with dilated cardiomyopathy of unknown etiology, and also in patients with intermediate risk of coronary artery disease, this stress MRI is usually very useful. And coming to, this is a picture showing different types of myocardium, what we've seen while evaluating in adenosine stress MRI. Now, if you look at the middle panel, this is the ischemic myocardium, and this is the infarcted myocardium. The first one is the normal myocardium. If you look at the ischemic myocardium, under stress, you see a perfusion defect. Okay, and in infarcted myocardium also you see a perfusion defect. But when you look at the late gadolinium enhancement, there is no enhancement in the ischemic area, whereas there is definite enhancement in the infarcted area. So imagine not having the stress perfusion at all. Then we will think that this non-enhancing area is also a healthy myocardium, where in fact it is actually a ischemic myocardium. So this is the main role of identifying reversible perfusion defect in adenosine MRI. This is another panel from the internet to show that what exactly we evaluate in adenosine MRI. Now the lower panel is a rest perfusion and the upper panel is the stress perfusion. What you see is there is a defect in the hereditary. There is a perfusion defect, stress perfusion defect in the hereditary, which is disappearing in rest imaging. So that means this is a rest perfusion defect. So this is what we want to, this indicates this is an ischemic myocardium. This is prone to further disease if it is left alone like that. So this is what we need to address clinically, and we have to detect this ischemic myocardium using stress MRI. Similarly, in dobutamine MRI, what we're looking for is we are trying to see the contractile reserve of the ventricle. So imagine a hibernating myocardium which is normal thickness, but it is not contracting well. In that case, the ventricular function is decreased. So when you give dobutamine, it improves the contractility of heart. So some segments which are infarcted are completely non-viable. They will not improve after you give a stress dobutamine dose. Whereas hibernating segments will show improved contractility and systolic thickening in dobutamine MRI. So this way we can say that that particular segment is definitely hibernating, and it is there is a chance of recovery in that particular segment. And also we can detect new abnormalities which are not seen in rest imaging in dobutamine MRI, so unsuspecting territories. So we can again go back to the angio information and address whether there is any important plaque or a obstructive lesion in that particular territory where you see unsuspecting new wall motion abnormalities in dobutamine MRI. Now, this is actually one patient we have done in Vijaya Diagnostics. Parametric imaging, like I said, has increased role these days in cardiac MRI, where they do T1, T2 mapping and ECV maps. We basically want to see fibrosis in the myocardium. Okay, in patients where you cannot give IV contrast, you cannot do the late gadolinium sequence because of the risk of nephrogenic systemic fibrosis. In such situations, you still want to see what percentage, or at least get an idea of which territory of myocardium is diseased, having non-viable scarred and fibrous tissue. This patient, we could not give IV contrast, but we did a normal imaging and we could see the thinned out myocardium in hereditary. And that particular area was also showing increased T1 values in parametric imaging, confirming that there is definite fibrosis and scar tissue in this area. So in this situation where you cannot give IV contrast, parametric imaging has a very important role to play. Now, we saw different types of images. Okay, now we are going to see a little bit about the complications of ischemic heart disease, where you can very clearly depict and identify in cardiac MRI. This is one patient infarct, and then there was a non-enhancing filling defect at the LV apical cavity, which is suggestive of a left ventricular thrombus. So this is one of the complications, and it can be well identified in cardiac MRI. And this is another important feature, which is microvascular obstruction. In this infarcted enhancing myocardium in hereditary, you can see one mid-myocardial non-enhancing part of myocardium. This indicates microvascular obstruction or a no reflow phenomenon. It's usually seen in patients post-revascularization, where one segment of the myocardium will not show any enhancement. This is due to destruction of the capillary bed, where the contrast will not go into the interstitial space. This is actually a very important thing to mention as a radiologist, to identify this finding and mention it, because this has a poor prognostic outcome if such a microvascular obstruction is present. So again, MRI gives us an added advantage to detect these findings as well. Now, this one patient came to us with clinically suspected ischemic heart disease, young patient. biochemically also suspected, but coronary artery disease angiogram revealed only mild disease in LAD and not significant. So they have sent us for cardiac MRI, and actually we found that there was ischemic myocardium with a perfusion defect and a small thrombus as well in the LAD territory. So this again shows the importance of cardiac MRI in confirming the diagnosis, because cardiac angiogram was normal, and they were not they were not sure as to why the patient is symptomatic and why there are other parameters which are abnormal. So therefore MRI really helped us to confirm that this is actually ischemia going on, and that could have been a recanalized vessel which is probably looking normal or near normal in angiogram. So I would also like to tell you that this MINOCA is actually, what it means is myocardial infarction with non-obstructive coronary arteries, which is self. The meaning is there within the name itself. Now, this is another patient who also came with chest pain, and they were evaluating for a chest pain, and then they were sent for a cardiac MRI to look for an ischemic myocardium. But in fact, this patient actually had epicardial enhancement, which is not typical of ischemic disease. So this patient again, there was history of COVID infection recently, and this was done a few years back during the time of COVID. So this actually was a case of viral myocarditis masquerading as ischemic heart disease. So again, cardiac MRI can again diagnose unsuspecting myocardial pathologies as well. Now, there are recent advances like strain imaging in cardiac MRI, where there is feature tracking and other tracking analysis, where we get information on the alteration in the longitudinal and strain of the myocardium. So again, this particular domain of cardiac MRI, also there is a lot of work being done to help in early identification of ventricular dysfunction in ischemic heart disease and other diseases as well. So what are the advantages of MRI? Generally, there is no radiation in MRI, so that is definitely an advantage, and we have excellent spatial resolution. And like I said, we can detect extra cardiac and other coexisting pathologies as well. Now, people may be wondering whether MRI is advantageous than the usual nuclear medicine imaging like stress thallium and SPECT imaging. Yes, it is, because there are studies have shown increased sensitivity and specificity accuracy of cardiac MRI over SPECT imaging, where there is increased spatial resolution. We can get to see subendocardial infarctions in cardiac MRI, which may not be able to see in thallium imaging. And generally speaking, the sensitivity and specificity is also much more than SPECT imaging. Now, if I have to conclude my talk and just give one take-home message for today's talk, I would say that cardiac MRI is generally a one-stop investigation for complete and comprehensive assessment of myocardium and ischemic heart disease. So these are my references for today, and I really thank you all for this wonderful opportunity to interact with you all. Thank you for your patient listening.
Yeah, it was an excellent talk, sir. Very excellent, informative, and exhaustive talk regarding ischemic heart disease imaging. Yeah, very useful for the young radiologists and even the cardiologists to enhance their knowledge regarding the imaging features. I request Ravikanth sir to give a few comments about the talk and any doubts if we have any.
Once again, thank you. The excellent presentation by Dr. Deepak. Very elaborate discussion on the when to do indications, as well as what are the findings, what are the things to look into cardiac MRI when assess the ischemia as well as for viable myocardium. I've got few comments. This is the after in MI, how many days after revascularization, say primary PCA, still there's significant LV dysfunction. To assess the scar burden and viable myocardium, or after MI, you have done an angiogram, you have a triple vessel disease, whether to send revascularized surgery, how long one to wait. So when is the time interval to send the case to cardiac MRI in view of the MVO, that is microvascular obstruction? What is in 1 week or is it 10 days? Generally, what our guideline says, 1 week to 10 days. After you do a primary PCA, scar assessment is better if you do after 1 week or 10 days. By that
Absolutely,
time, there will be differentiating between the MVO and scar tissue becomes little better. But what is the practical implication of this? I would like to you to elaborate. Second is, in general, scar tissue is there more than less than 25%. We are sure that you can subject them to revascularization. If it is more than 75, in general, it is and it's percentage of the scar tissue when it is there. Uh, can we quantify the viable myocardium in that? That is obviously more important. If it is significantly more viable myocardium is there in relation to scar, then the predictability for recovery is much higher compared to you have a viable myocardium here and there, but it's not very significant or that can we quantify the viable myocardium in segments wise, say that is more important. And as parametric imaging, that is wonderful. Actually, native T1 mapping that will be helpful in especially myocarditis, whether are we dealing with those kind of situations. It is very helpful. Thank you, Dr. Deepak, for your excellent presentation. I just want these clarifications. If you
Yes.
can just highlight or
Yes, sir. Yes.
answer those.
Certainly, certainly. Yes. So, like you, the first point what we were discussed is what is the correct time to do a cardiac MRI after recent myocardial infarction or a PCI? Yes, sir. We also in radiology also we discussed that it is about 10 days, because if you do in the first 10 days there is overestimation of scar burden. I have shown you an image of edema imaging that actually helps us to see what percentage of myocardium is edematous and abnormal. But it is difficult to tell in an acute situation what person is actually infarcted and what is edematous and what is inflamed. This differentiation is very blurred in the first 10 days after an insult. Therefore, after 10 days is generally an ideal time to do to that differentiation, that blurring between diseased inflammatory or myocardium and the normal myocardium is becomes more sharper in the first after the first 10 days. So therefore, we advise generally to wait for 10 days to do a cardiac MRI. If we do in the if it is inevitable, you have to do in the first week, yes, but we have to understand that there may be a overestimation of scar burden in such a situation. Second point which you said is, can we accurately identify or quantify the scar burden? Yes, sir, certainly we can quantify. So there are certain parameters in a particular cross-sectional segment of the 17 segments of heart. If more than 60% of the segment is showing abnormal enhancement, that means it is considered as non-viable. And also we look at the pattern of enhancement. If it is thinned out, akinetic, and if it's showing transmural enhancement, that is non-viable. So we add up all these segments and we get a final value. That is, it is multiplied into 16 so that we get a final value. Or we can do a statistical assessment as well, which the computer software will generate a report. Usually at the end of the report, what we get is, we can say that of the 17 segments of LV myocardium, 8 are non-viable. So roughly about 48% of myocardium of LV is non-viable. And we can also exactly say, based on if we have the angiogram information, we see which dominant circulation it is, right or left, and then we see where all the blocks are, and then we can correctly say what percentage of this myocardium is there in hereditary. Hereditary, how many segments are non-viable? LCX hereditary, how many are non-viable? RCA, how many are non-viable? This information also we can give clubbed with the angiogram information. So accurately we can tell, sir, definitely.
Thank you for your clarifying my doubts.
Welcome, sir.
So I have one doubt. Generally, we do this cardiac imaging on 3 Tesla. So is like doing in 1.5 Tesla is also okay, the spatial resolution and signal?
Yes, it is okay. It is okay. There is marginal improved clarity in 3 Tesla when we have to look at the subendocardial infarction and parametric imaging and all that. But yes, until a few years back, the most of the cardiac imaging was done in 1.5 Tesla, and there have been excellent results in that. So there is no problem doing cardiac MRI in 1.5 also. Absolutely fine.
Yeah. And in one slide, you said like transmural enhancement, we can see also in other pathologies like sarcoid, etc. So how to differentiate that, like from the ischemic thing and the infiltrative pathologies like sarcoidosis?
Yes. So yes, that is actually a very important point. So if there is transmural enhancement in other diseases, how we differentiate is that we look at the pattern of enhancement, the uh, the distribution of enhancement in the left ventricular myocardium. That is very important. We will see whether it's conforming to an arterial territory. Like in one of the images that I showed, the demarcation between long and abnormal myocardium was very sharp. We could see the infarcted transmural infarction being very sharp. Okay, and this sharpness is not there in other infiltrative pathologies. It's usually blurred, and usually if it is, for example, sarcoidosis, which also can show transmural enhancement, there'll be different patterns of enhancement in the same patient, same subject. That is, you can have mid-myocardial, epicardial, transmural, and subendocardial, called as polymorphic type of late girdle enhancement, different patterns in the same patient. So if you see such a thing, then again it tilts more into towards the sarcoidosis or any inflammatory myocarditis. And we also look at extra cardiac findings as well to help tilt the diagnosis more in favor of non-ischemic pathologies. For example, if you see mediastinal, significant necrotic mediastinal lymphadenopathy, pleural effusion, or any lung infiltrates, we can definitely think more in favor of sarcoidosis rather than ischemic myocardium. But yes, like you said, even if we have transmural enhancement in different pathologies, based on these parameters, we can, to a certain extent, definitely differentiate between ischemic and non-ischemic pattern of enhancement.
Thank you. So I think there are no more doubts from the audience.
One clarification, can I?
Yeah,
Yes,
sure.
sir.
Most of the patients of LV dysfunction are in the LVF. They cannot breath hold for 10 seconds. Can we perform cardiac MRI for viable study, especially in irregular ectopics or atrial fibrillation is very difficult. But at least in frequent ectopics, can we do it in a 1 or 2 cardiac cycles viable assessment? Is it possible with 3 Tesla or still difficult to do?
Yes, sir. That is a very practical point you highlighted. In fact, we also have sometimes we spend time in patients who are finding it difficult to hold breath. Yes, but the prerequisite is they should hold a breath for at least 10 to 15 seconds. Number one. If they are unable to do so, there are newer modalities like real-time scene imaging, where patient need not hold breath for so long, and image is done on a real-time beating heart. The images may not be so clear like what we do normally, but they are almost 80 to 90% there, and we get the information we require. So there are newer developments in this area where we can do imaging even in patients who cannot hold the breath properly. Secondly, if the heart rate is less than 40, sometimes it's difficult to do the scan. The machine will reject that particular cardiac cycle. Or if in arrhythmia patients, obviously we cannot get a good ECG trace, and it's difficult to do a gated study. So therefore, anywhere in between, if it's not atrial fibrillation, if it is not severe bradycardia, in these areas, it is time consuming, but definitely we can do, and we have done and succeeded in this kind of situations. It may take time, in the sense we may do a initial image that may be blurred. Then again we do. In the next cardiac cycle, maybe they may not be a conduction abnormality, and that image will be better than what we got previously. So we keep doing until we get a better image, and it's slightly more time consuming. But there are, like I said, there are newer modalities like real-time imaging, cine imaging, where we can get better images in this particular group of patients.
Thank you for your valuable information.
I think there are no more questions from the audience. So I hope these videos will be uploaded in the social media. So I hope that the increase in number of cardiac MRIs in Vijaya Diagnostic. After seeing these videos, I think we'll get more number of patients for imaging in ischemic heart disease. I thank Ravikant sir for attending today's webinar in spite of his busy schedule. He made time for attending this webinar. And I thank Deepak sir for an excellent talk. I thank Krishnamohan sir for giving this opportunity to host this webinar session, and the audiovisual team and IT team for making this happen. Thank you. We'll conclude.
Thank you all. Thank you.
Thank you, sir.